Thank you very much. Thank you again for inviting me to be here today. I too am very excited. So the question is, are we overtreating May-Thurner syndrome in 2022? I have no disclosures. May-Thurner syndrome is commonly thought of as compression of the left common iliac vein by the right common iliac artery. It is thought that this compression is what leads to the fivefold increase in incidence of DVT in the left lower extremity versus the right. In 1957, when May and Thurner first reported on their syndrome, based on their study of 430 cadavers, they were the first at that time to ascribe the constellation of symptoms to not only compression of that common iliac vein, but also a spur at the left common iliac vein IVC confluence. Spurs are actually common. About a third of patients who have no symptoms have spurs. Compression is also common. Even high incidence of compression, up to 44% in some studies, are not necessarily associated with symptoms. Even in those patients that have collaterals, surprisingly, not necessarily correlated with symptoms. So left common iliac vein compression being present in about a third of all asymptomatic patients, this is considered a normal anatomic variant. Really, to have May-Thurner syndrome, you probably need not only compression, but some degree of venous scarring and a relation to venous hypertension symptoms. So, treatment of venous insufficiency. Over the past half of a century, the treatment of chronic venous disease has been focused on treatment of superficial venous reflux. But as we got a little bit better and much more frequently using of endovascular techniques, this opened the door to iliocaval outflow obstruction. About 10 to 30% of cases of severe chronic venous insufficiency have some degree of iliocaval outflow obstruction. And so over the past 2 decades, this has blossomed. So what is the rationale for this treatment? Well, open bypass, we know, is associated with very high morbidity and mortality. Venous stenting, by contrast, has been shown to have an extremely low risk of early complications. It's relatively easy to do, can be performed by different types of physicians. Anticoagulation alone, we know, is not always enough, especially in those who have post-thrombotic syndrome. There's a hypothetical preservation of valve function in DVT, and the treatment of post-thrombotic syndrome costs $15 billion annually in the United States. There is evidence to support this treatment as well. In this sentinel paper by Raju, he reported on 982 lesions and showed that there was 78% partial or complete pain relief at 5 years. A recent meta-analysis that looked at the non-thrombotic iliac vein stent use showed pretty favorable results. Technical success was 96%, 1-year primary patency 96%, and as far as symptoms go, pain, edema, ulcer healing, all relatively favorable. There are a few limitations I should mention for all of these studies. There is no consensus about how to measure venous stenosis. Do we look at area reduction, percent stenosis? The shape of the vein has been reported in some studies, or duplex waveforms. There is no consensus, and there is certainly no predictability from one study to another. So the limitations of imaging, in addition to the fact that we don't even know what we're looking for, should we use CAT scan, should we use duplex, should we use MRI, even IVUS obviously should most likely always be used. These are all limited by the fact that hydration status affects your findings, the timing of the studies can affect your findings, the quality, and these studies are often operator dependent, particularly with duplex and IVUS. Now, the National Venous Registry in the UK reported on patients with May-Thurner and DVT, and they reported that their 1-year patency was significantly better in limbs treated with stents versus lysis alone. So in patients who had May-Thurner and DVT, they did better if they were stented versus not stented. So what are our current recommendations? So May-Thurner syndrome after DVT lysis, the Society for Vascular Surgery, Society for Interventional Radiology, American Heart Association, American College of Chest Physicians all recommend stent. As far as a patient with May-Thurner syndrome with severe chronic venous disease, no thrombosis, simply just chronic venous disease. These societies, including our SVS and American Venous Forum, all recommend a stent. But they all cite that the evidence is very weak. So in order to answer this question of, are we treating too much May-Thurner at this point, we have to consider the risks of treatment. So the risk of treatment is not insignificant. It's been reported up to 61% in Dr. Raju's paper at 5 years. This is a very important problem that you see. The risk of contralateral DVT after stent placement has been shown to be up to 10% at 1 year out. So about 10% of patients may experience a DVT a year after having an iliac vein stent placed. This should be part of your informed consent. I know it is part of mine. The reintervention rates up to 40% have been reported. And chronic back pain is typical, but usually self-limiting in most cases. But it has been reported that back pain can persist so long as to require excision of the stent. Stent fracture is another problem that we have to be concerned about. Now, usually, stenting across the inguinal ligament is well tolerated in this treatment. In fact, quite often you have to stent across the inguinal ligament in order to get inflow into your venous stent. However, stent fracture occurs, particularly if you have two stents overlapping within 1 inch of that inguinal ligament. Stent migration is even one of the more worrisome complications. If that stent doesn't stay still in the iliac vein, the next pinch point is the tricuspid valve, and that would usually require open heart surgery in order to remove it. So there are a number of studies that have shown us some factors that can predict stent failure, like thrombotic etiology, occlusive lesions, and a younger patient. However, despite this, we still have no idea which stent will stay patent and which won't. The NICE guidelines should be a very serious warning. They are the guidelines that have severely restricted EVAR use in the UK. And this should be a warning to us here that for the potential for government regulation in a situation where there is perceived overuse or overtreatment of a disorder. There are a number of studies now looking at overuse of medical technology. So let's consider a couple of clinical scenarios. Now, most vascular surgeons I've spoken to say that they would generally only treat May-Thurner syndrome with an iliac vein stent for CEEP4 disease or worse, right? And so I think that there's a fairly good consensus by most vascular surgeons that they would try to avoid treating in somebody who had less than CEEP4 disease, but should we consider others? So what should we do for a patient with CEEP2 disease, varicose veins that hurt? Should the patient be treated? Well, yes, we should treat their superficial venous reflux. Iliocaval compression will be present up to 10 to 30% of these patients potentially. So it's common, but it's incidental and should not be treated. So bilateral edema, again, look for all other causes of your edema. It's not necessarily going to be from the May-Thurner that they may or may not have. So look for renal insufficiency, congestive heart failure, morbid obesity. And if you must treat for edema, which is still potentially acceptable, you should really probably treat the more symptomatic side first. So sometimes we are tempted to put bilateral iliac vein stents. That is not answered. I would recommend that we treat one side, the more symptomatic side first, because of those cross-pelvic collaterals, sometimes both legs will improve with just stenting one side. So for lymphedema doesn't hurt. So it really doesn't make any sense to treat a patient with lymphedema with an iliac vein stent, obviously. But some patients get secondary lymphedema from chronic venous insufficiency. So for post-thrombotic syndrome and pain associated with that, that would be one scenario where secondary lymphedema might get better with an iliac vein stent. Morbid obesity should be considered a relative contraindication to this technique, to this treatment. These patients generally have a venous insufficiency that comes from their central obesity and their central pressure that is elevated. And so I would never treat a patient who is morbidly obese. It's just a procedure that is doomed to fail. It's also very hard to do surveillance on them. You can't easily do duplex ultrasound afterwards to make sure their stent is patent. So another reason not to treat those. So what we need more than anything is more studies. You know, the Medicare Evidence Development and Coverage Advisory Committee has pushed hard for us to produce more evidence in terms of the efficacy of venous procedures. In addition to our limited understanding of the general venous hemodynamics, there are a number of other unanswered questions we have, like anticoagulation, how long do we treat, who do we treat, antiplatelets, surveillance, do we treat pregnant patients or patients with potential future pregnancies, the best scoring systems as far as quality of life, and the actual definition of May-Thurner syndrome. We still don't know what is a clinical pathologic condition and what is just a normal variant. Future study designs should include stratification by indication, because this is not always done in these studies and series that tend to be limited numbers, because the outcomes are clearly very different. And as Peter Glowicki said, we need to focus on venous research and never forget that whoever owns the research will own the disease. And put more bluntly by my friend Jean Bismuth and his editorial in the Vascular Specialist, he thinks that our understanding of the venous hemodynamics is quite primitive, and there doesn't seem to be much fascination with comprehension of the disease, but there appears to be an enormous drive from a variety of specialists to do procedures. So we need to push this curve, a little bit less opinion and a little bit more evidence, and hopefully we'll be able to figure this out. Thank you.